Obviously, the best way to know if the work we're doing is an improvement is through the stories we heard this morning. I think sharing the patient stories is the key way we'll ever know how we're doing and how it's making a difference. But there are some data pieces to that to sort of put some meat behind those stories as well. So that's what I'll talk about this morning. So I'm going to give you a quick run through about how we selected the measures to know if what we're doing is working, the process behind it, and then some of the initial results that we're seeing. And then I'm going to pass it over to Joy to show how one piece of work can have an effect on multiple measures and multiple drivers. So when I'm working on an improvement project, I always kind of like to go back to the basics. And for me, that's looking through the model for improvement, which asks three basic questions. What are we trying to accomplish? How are we going to know if we're accomplishing it? And then what can we try to see if we can accomplish that? So for this initiative, fairly obviously, the what are we trying to accomplish has already been laid out. It's that 60% reduction in emergency department wait times. That's our North Star, so that I didn't need to worry about. But what I am worrying about is how are we going to know if our changes are making an improvement? So to do this, what I did was engage a group of senior leaders and measurement experts and information technology practitioners from around the province to determine what an appropriate set of measures are and how we would go about collecting that data. It took multiple meetings and many, many discussions, but we did come to an agreement on what we would be measuring. In determining these measures, it was important to choose something that would strike the balance between the information the initiative needs to know if it's working, but that would also be useful at the point of care, because it's something that we want to have used in multiple purposes. So the measures we selected ended up getting broken up into three main categories: the initiative measures, acute care measures, and community care measures. Now, the initiative measures were pretty obvious for us. They're part of the Ministry of Health's annual health system plan. So those were set out, we knew we'd have to measure them. They include things like time waiting for an inpatient bed, time to physician initial assessment, emergency department length of stays. The acute care measures were selected because of the key drivers of emergency department waits. These include things like the length of stay in acute care, the hospital occupancy, a lot of information around alternate level of care, which Graham mentioned, and then a high-quality care transition measure around how you get patients back out of the hospital to their community and wrap that team around them. The community care measures were a lot more difficult to select. We ended up landing on measures that would look at things that would change if you're receiving quality care in your community. So while the measures kind of do look more acute focused, it's because we thought if you're receiving proper care in your community, these are the things that'll be changing. We also added a high-quality care transition measure in there around follow-up calls within 48 hours of discharge. Again, that's just sort of a best practice that we've seen in the literature. So this slide, even though I'm sorry you probably can't read it because I can't read it and I'm that close to it, but this shows the full ED weights driver diagram. And for those of you that may not know what a driver diagram is, essentially it's a logic model for you take your big, large goal and you put it over here on the left-hand side, and then you break that down into manageable pieces of work so that you can take this big thing, but instead of trying to boil the ocean, you can take your little pieces, and if they all add up, hopefully you'll achieve your goal. So this diagram has been reorganized slightly since it was unveiled a couple of years ago. And this is because of the knowledge we've gained through the work that your teams have done and through the health system model to know what the things are that we can use to affect change. So for the emergency department wait times, there's three primary drivers, and those are things like hospital occupancy, access to community services, and the emergency department optimization. So why I really like driver diagrams as a tool is because once you've got one completed, you can actually hang some measures onto it. And that's what these little yellow boxes are. And these are the measures that we've selected as part of monitoring the connected care system. So you can see we've kind of got the whole broad range covered. At least we'd like to think we're doing a good job at the start, and we'll continue to evaluate and figure out where our gaps are as we go. Those darker orange boxes are things that other initiatives or strategic project teams at the Ministry of Health are looking at. So even though they're not necessarily being measured by us, they are being looked at by others, which shows how cross-functional this work truly is. So another thing that I did to make sure we're starting to look at the right measures we're looking at the right measures, is to look at a bit of a process map instead. So what I've got here is a pretty high-level thought of how care occurs. So patients start in the community, then they may transition into acute, and then they may transition back into community. I've taken those exact same measures I mentioned a couple minutes ago and put them in the sort of correct column for community, hospital, or back into community. You can see again that we've got a large section covered. So that's why I think we've got the right set of measures selected. What is also interesting about this is if you took this and flipped it on its side It looks like that driver diagram. So up here again is our hospital occupancy and mortality rates. It's those high-level drivers, high-level goals, and then everything cascades down from there, which makes good sense. So what I'd like to do first, before I get into the initial results, is thank some of the people that are here in the room for the work that they've put in to get me the data required to do some of this. So I know there's a bunch of people in Saskatoon and Regina that have spent the last couple of weeks pulling data, getting reports together, and sending it off to me so that I could start pulling this together to put in a presentation for today. So thank you for all your work. And if the leaders are here and their team members aren't, I'd like you to pass that back along to them, because I know how much work it must have been. So the first story is an actual, truly a good news story. It started in the Regina Leader Post a couple weeks ago, and it's about how emergency department wait times are slowly improving in RQHR. Just to be totally honest, when I saw this story, I was kind of worried that just a random fluctuation in the data was being reported as a big change. So I decided to do what made sense to me, and I dug into it. So what I did was create a control chart, and in case you're not familiar with the control chart, that's quite fine. But essentially what they do is they show your data over time, so that time goes along this way on the axis, and then there's two lines where you would sort of expect your data to normally be. So if you can imagine an example of how long it takes you to drive to work, it's not always going to take you 8 minutes. It might be 7 some days, 9 some days, but you know it's going to be in kind of a range. That's what we can do with measures in healthcare as well. So this is the emergency department wait time in Regina, and what we're actually seeing over here on the right-hand side is something special is happening that's causing that change. The mathematics are saying, you know what, something really is different here. So that's why it was a really good news story, and I'm glad it was shared with the Regina Leader Post. And I'm guessing that this is because of all the work RQ's been doing around accountable care units and redesigning their community care services. So again, kudos to you and your teams. I also looked at that exact same measure in Saskatoon. And again, same idea. It was kind of floating along where we'd expect it to be, but we are seeing some special cause in here. So something is changing in Saskatoon as well that's causing your ER department wait times to not be where we would expect them to be, and that's a good thing because they're actually being reduced. Another measure that caught my eye was the length of stay on 7F in St. Paul's Hospital, which is actually the unit where they've opened up the accountable care unit starting on April 1st. So again, on this unit, the length of stay for patients was kind of somewhere between 8 and 16 days, depending on the patient, and that was expected. It'd be somewhere in there. But we're seeing 2 points over here that are unexpected. They're out of those control limits. They're meeting some of the mathematical rules to say something different is happening here, something good. So that's why I'm excited about these measurements, is because we're actually starting to see how that work you're doing is performing. Another thing that caught my eye was the 7-day revisit rate in Regina. So we were kind of at a certain rate here, and then it shifted, and it's still predictable now, but it's predictable in a better way. So we're seeing a lot less patients come back to the emergency department after receiving service in Regina. So I'm hoping the entire suite of measures will continue to show the good news stories like this as we continue to move forward. I haven't done a full analysis on everything, but these are the ones that quickly jumped out at me. I wanted to share them today to show that you have been doing good work, and we'll be able to track that and share it out. So the next steps are to continue developing the reporting product for Saskatoon and Regina. Essentially, I've got all the data in, I'm trying to turn it into graphs, try and put it back into something that's easily digestible and you can kind of get the facts out of quickly. But that's not to say this just applies to Saskatoon and Regina. These measures we're hoping can be used anywhere in the province by any team, whether it's in a small facility, whether it's a single physician in a community. And we've got operational definitions and methodologies on how to collect all of them. So if you're interested in starting to collect some of these and you're not in Saskatoon or Regina, please absolutely do. The more information we get, the better. And then, of course, just that sort of the note of we're continuing to learn as we go. This is just a start. So these may not be the perfect set of measures, and I'm betting they're not. But as we continue to learn, we'll continue to add or take things away based on what we need. We also know that there is a bit of a gap in here. We're measuring patient flow. We're not necessarily measuring patient experience at this point, and I want to highlight that to say it's not off of our radar. There is a group called the Patient Experience Working Group, which one of my colleagues is leading, that is going to look at developing a survey for the connected care system, so we can ask how patients are doing, how they're feeling about the care in this new system as opposed to the old system. And that's how we hope to capture some of that patient voice. So even though I haven't mentioned it today, I wanted to make sure that it is out there and known. So at this point, I'm going to pass it over to Joy Dobson to talk about a piece of work that essentially, I like this metaphor. It's a triple word score, and that's something a former CEO of Saskatoon Health Region used to say. It's That one piece of work that affects multiple drivers and multiple measures, and you get a lot of results from just doing one thing. So over to you, Joy.
Well, thanks, Doug. I'm going to use a modified Pechakucha format, which means 15 slides in about 15 seconds each, to show you how the work of one organization here today is contributing to connected care metrics. Just as a bit of background, 3S Health was created in 2010 with a mandate to find $100 million in savings for the health system over 5 years. Well, what you measure is what you improve. Now the goal is to deliver and report on quality with the same rigor and success. That will mean measuring total value, not just cost, for the 1.2 million citizens and 44,000 providers that we touch. We do this by standardizing to best practice across the province. Smart pumps mean every patient in Saskatchewan gets the same high-quality intravenous medications care. And new epidural kits mean every anesthesiologist has a tool that prevents complications. But 3S Health, oh, something's wrong on my slides here. Yeah, I know, but anyway, I'm off on my Pechakucha. So 3S Health Transcription is working on a lot of these touch points. The turnaround times now for medical imaging reports are measured in minutes and hours, so the team has the full report in hand instantly. When patients do require admission, the reports are on the chart. It's set on auto advance, but maybe you're going to take it off. Sorry. We have now reports that are entered into the patient chart and in Sunrise Clinical Manager instantly, and so we've actually had to slow some down because the patient isn't even out of recovery room and the operative report is ready to be sent to the ward. One more now. This one we can stay on here. I'll do it manually, thanks. Phew, pressure's off. The family doctor is automatically copied on patient reports. And that means when the patient shows up in clinic or the office for follow-up, the doctor has all the needed information in hand to continue the plan of care. And that means the riskiest handover the patient care faces, that discharge from hospital to community, is now safer. High-quality transitions mean fewer return visits to ER and avoiding early readmissions to hospital. Good management of chronic diseases is increasingly complex and is part of reducing unnecessary and repeat hospital admissions. We could make it easier to reliably provide best practice care by embedding guidelines or links to resources right into the patient care reports. Waiting to see a specialist for needed treatment and advice is waste. Standard templates help ensure that the right information is shared to minimize the wait, but more importantly, maximize the value of that consult. To reach the goal of no patients waiting in emergency, we're all going to need to pull together. Everyone in this room has an oar in the water. Butch and Tessa's dad and my dad rely on us for all these care decisions to make sure that they are getting those high-quality transitions. Because this is the real metric that we're all working on, that no patient spends a single extra night in hospital or a single extra hour on an ER stretcher when they could be at home. Thanks.